Thank you very much, Luke, for inviting me here. And I'm really happy to be here, but I feel very humbled to be here because I don't have any brilliant insights on pathogenesis. I don't make a lot of ingenious gadgets and diagnostic devices, and I don't do molecular epidemiology. But instead, shortly after my PhD, and I did do some pathogenesis in my PhD, I was asked to set up the National Reference Lab in Canada for chlamydia. That was at a time when all the molecular technology for diagnosis of infections were just starting. So Roche PCR, the Abbott LCR, et cetera. And my job was to evaluate these new technologies and look at cost implications. And then I was asked to go to the WHO first to look at how to get cheaper and more affordable diagnostics for STDs into developing countries. And then with that, when I succeeded a little bit in doing that, I was asked to apply that to all the tropical diseases, for which quite often there are no diagnostic tests, and mass treatment is the general strategy. And so now I think that at this day and age, with a lot of antimicrobial resistance and drug susceptibility, I think we need to look at the value of diagnostics and what we must do to try and overcome all the gaps that we have in trying to improve global health. And so what I'd like to do is to go over the landscape in general of diagnostics in the developing world. Okay, thank you. And look at what we do need to do in order to improve health in these high-burden countries in particular, and figure out a way forward. And I must say at this point, we don't have many answers, but I think we have the beginnings of something really interesting and very promising. Now, in much of the developing world, there's very little industry interest in diagnostics R&D. Especially for diseases that are only prevalent in the developing world, mainly because there's a perception that there's no return for investment. And so in terms of the diagnostic industry, the big 10 companies, 80% of their market is in the developed world. And so only 15% of their diagnostics are used in the developing world. And also, in the developing world, there's a limited access to diagnostics and diagnostic services, mainly because governments don't actually prioritize diagnostics. And I'll show you a little bit of that data. And clinics often suffer from frequent stockouts of reagents. They don't have enough people, and so there's a shortage of staff. And so they turn out bad results, and it's a bad cycle because doctors don't like to get these results that misguide them in terms of management of patients. So they stop ordering tests from the lab. And because of that, there's less and less investment in labs. And so that's something that really needs to be changed. And in terms of the regulatory landscape, there are many countries that actually don't have stringent authorities for approving diagnostic devices. And with the effect that tests are sold and used without much evidence that they work. And I'll show you some of that data from a survey that we did when I was at WHO. And finally, there's a lack of quality standards in how to evaluate diagnostics. So quite often you see in the developing world, when you look at the product insert of tests that are being used in the developing world, they'll say they have 100% sensitivity and 100% specificity. And when you really ask these companies, how many patients did you use to get that data? And actually, there was one company that said 15 patients. And I said, how many of these patients are positive for this disease? And they said 3. And so you cannot really, you're often misled into buying products that are no good. Now, This is a statement that's from the Lewin report, which was commissioned by the American Diagnostic Manufacturers Association to look at the value of diagnostics. And they found that in the US, while diagnostics only comprised less than 5% of hospital costs and about 1.6% of all Medicare costs, their findings actually influence as much as 60 to 70% of decision making. Now, similarly, in the developing world, there was a WHO study looking at Malawi cost distribution of a health center level in Malawi, and they found that only 60% of their expenses are on diagnostics. And this is hopefully changing a little bit. When I was in WHO, we decided to actually look at how many countries actually regulate in vitro diagnostics outside of blood banking diagnostics, because many countries do have more stringent requirements for blood banking diagnostics, like for HIV, et cetera, hepatitis. And we sent our survey to, at that time, there were 191 countries in the UN. And we sent out a survey to all the countries, and we got 85 responses, which is not bad, I guess, on the whole. And sadly, though, less than half of the countries actually don't regulate in vitro diagnostics. And you could see from the, whoops, sorry. Okay. For pointing. Okay. So you could see that in different regions of the world, there are more or less countries that regulate diagnostics. And so in Europe, a lot of countries do. But generally in Asia and in Africa, a lot of countries don't regulate diagnostics. And so that means anybody can register their product and sell. Now, in terms of what's happening, so we did a more detailed survey, and we found that the diagnostic landscape varies, even with the countries that do regulate diagnostic, but quite often is not transparent. So the process is not open to, so companies actually have to keep submitting and submitting, paying more money in the hopes that they would get approved. And so the lack of transparency is really not helping in terms of trying to get your product to be used and sold and used in countries. And a lot of the approval processes actually don't require any quality, no clinical trials. And so companies can do their own clinical trials, use that data and submit it. So that's why you have a lot of product inserts that says that their product is perfect. And then also there's been a global harmonization task force to look at harmonizing regulatory approval processes so that companies don't have to go into every single country and do a regulatory trial. But there's been very limited success. That global harmonization task force has been in existence since 1992, and there's been really no harmonization that has really happened. So the result is that, as I said, tests are sold and used in the developing world without much evidence that they exist, that they are effective. But what's more is that companies with really good products are really unwilling to go into a market that's flooded with bad tests, because either their product has to sell for more, because quite often a lot of the low quality products are just a strip. Some of them have no reagents inside. And so of course, you know, if you have a good product, you cost a little more to make that. And so you're not competitive. And also, the cost of the regulatory trials are just too much for smaller companies. And the result of that is that many of the smaller companies actually don't target smaller countries. And so I was looking at smaller countries in South America, and this lady who ran the national lab in Paraguay, she said, you know, for the Roche PCR for chlamydia and gonorrhea, how much do you pay in the US and Canada? And I said, you know, about $5. She said, in Paraguay, we pay $89. And it's because, you know, Roche doesn't have a representative in Paraguay. In order to get that test, they have to go through so many distribution channels. They have to pay so much taxes and transportation costs. That's what it ends up doing. And Paraguay is not a country that can afford $89 per test for chlamydia and gonorrhea. Now, how good are our tests? So WHO in 2004 and 5, in response to a lot of countries wanting information on dengue. I don't know how many of you have heard about dengue, but it's supposed to be the fastest growing vector-borne disease. And so many countries, when they have outbreaks of fever that they think is dengue, they want rapid tests to be used for outbreak control. So they commissioned Stuart Blaxell to actually evaluate these tests that are on the market. Now, on this side is a table of the claimed accuracy in terms of sensitivity and specificity of these tests that we found on the product insert. But on this side is a WHO evaluation using over 400 samples of positives and negatives. And so that's very sobering to know that some of these tests actually, you know, have very, very low sensitivity. Now, I would not say that these companies are trying to cheat, but it's just that sometimes they actually don't have access to good samples with which they could evaluate their tests. And so I'm happy to say that since this publication came out, many of the companies have improved their tests. Now, as Rebecca has mentioned, in the developing world, there's a lot of inequity in terms of access to diagnostics and diagnostic services. And in this table here, I've extracted from the 2004 World Health Report the distance that the poorest fifth percentile of the population has to travel in order to get to the nearest medical facility. And that's not to say that that facility will have a diagnostic test. And so you can see in some of these countries is 11 or 12 kilometers, 23, 27. Now, if you're sick or if you're pregnant, or you're carrying a child, that's a long distance to go in order to get help. And so, and then once you get there, sometimes there are no tests, sometimes they run out of drugs, and so there's a lot of problems in terms of inequity for diagnostics, in terms of diagnostic services. And so WHO has recommended syndromic management for fever, for STDs, etc. But syndromic management doesn't work very well for some syndromes. And so now, for example, pneumonia. If you don't have an idea of what are the pathogens causing pneumonia, and Stan had shown us that pneumonia is a major cause of death in children. But if you don't actually have an idea what are the top 3 or 5 causes of pneumonia, you wouldn't even know what to use to treat. And so in 2005, the Gates Foundation contracted the RAND Corporation to look at some models of looking at 2 things: balancing investments in a device that would increase access, so make it as simple as possible, or that you would have a device, or you would invest in a better test And so what they did was they have this table where they looked at the number of children's lives which would be saved if you were to have the ideal thing, would have a perfectly performing test that can be that could be used at a place with minimal infrastructure. And so you will save 500,000 babies' lives. But that's desirable, but not achievable. Now, if you would have invest in a good performing test in an advanced infrastructure, you would only save about half the children. So you would have lesser gain even with a perfect test. But if you make a test which can work in a minimal infrastructure, but maybe not a perfect test, you will be able to get significant gains that are potentially achievable. So always don't let the perfect be the enemy of the good in terms of thinking about what to introduce into the developing world. And so that's really helped in terms of thinking through what we need to get some, make some progress in terms of improving health through use of diagnostics. Now, what we wanted to do is to have this technological innovation where we could have a reasonable performing test working at a place with minimal infrastructure. But how much are we willing to trade for the performance? And for each disease, for each area, that may, that may vary a lot. And so the first thing is what we have now are these very, very simple lateral flow devices where there's a strip which is nitrocellulose, and we put onto it an antigen or antibody depending on what you try to detect. For example, if you're trying to detect antibodies to HIV, you would put an antigen there, and you put in whole blood or serum into this specimen well, and it'll wick across here. And when it crosses the area C, that's a control region, which is it's not a control for HIV, but it's a control that the specimen has actually reached there and passed through the antigen zone. And so if you only, at the end of 15 minutes, if you only have one line, that means it's negative. And if you have two lines, that means the person is positive for HIV antibody. And if you have no line, that means for some reason the specimen didn't migrate across. And so that could be because the blood sometimes has too much fat, or that the plastic casing is sometimes too tight, so the specimen doesn't migrate across. Now, with these types of tests, we found that there are really good HIV rapid tests, but we also found that there are really good rapid syphilis tests. And we know that right now, even today, there are still about 500,000 babies that die of congenital syphilis. When the test is 50 cents and a shot of penicillin to an infected mom to prevent the baby from getting the infection, it's very, very cheap. So for less than $1, you could have saved that baby. And what we found is in Haiti, where we worked, that because there was a really good PMT-CT program going on, screening pregnant women for HIV, a lot of the babies were born without HIV, so they managed to avoid HIV because of pre-MT-CT programs, but they die of syphilis. And so after spending several $1,000s on the mom, you could have just added $1 and do syphilis screening, but it's not often done. And so we got, very fortunately, we got some money from the Gates Foundation to look at introducing these rapid tests into areas where there's no previous screening or where there's pre-MT-CT programs going on. And so we want to challenge how much we can do in terms of gaining access. And so we took it into areas of the Amazon forest, where we actually And in this picture is a young Yanomami girl who is still actually in the deep of the forest. And she's, we told her about HIV, syphilis, and with, of course, the agreement of the government, we actually screened them for HIV and syphilis. And it's the first time that any diagnostic testing is done in this Amazonas region. And so the government of Brazil is really happy that at last they have a baseline in terms of, whether they need to institute a lot of control for these sexually transmitted infections in that region. And so we also introduced our testing in several areas. In China, where there's a big syphilis epidemic going on because of migration and a lot of sex work. In Haiti, where there's very little infrastructure, and also in Peru, and Brazil, Uganda, Tanzania, where we worked with the Elizabeth Glaser Pediatric AIDS Foundation to look at how cost-effective it is to integrate syphilis screening into preemptive CT programs, and also in Zambia. Now, what we found is that it's very easy to teach someone how to do the test. But in fact, what the things that we found, we totally didn't expect. We knew that there would be stockouts, throughout countries from time to time. But what we didn't expect, and we are trying to change that, is that in many countries, outside of big programs like the HIV program, the TB program, malaria program, when you talk about syphilis, and you want to introduce a new technology, they said, well, it's not my job. It's not anybody's job. You go around to several people, to the maternal and child health program, to the STD program, to the reproductive health program, and it all feel, they all fall between the cracks. The screening, everybody else thought everybody else was doing it. And then in terms of diagnostic technology, there's no real capacity for critical decision-making about what test to choose and what to use in what population in the country that makes sense. And so because of this, we actually started now an advanced course in diagnostics aimed at creating leadership for diagnostics in developing countries by teaching them about critical decision-making in terms of new technologies that are to come. So hopefully then there will be national bodies, like the national bodies for looking at new drugs. When a new drug is introduced, there is a national program that consider whether to adopt it or not. But a similar national committee doesn't exist for diagnostics in most countries. And also what we found also in talking to the governments about introducing rapid test technology is that at the very high level, at the policymaker level, they think that they have, for example, in this district that we work in Tanzania, it's a gold mining district called the Geita district. There's a lot of HIV, lots of STDs, and we started at a district hospital in Geita, and the policymakers told us that under the district hospital, there are 51 facilities, and 31 of them screen for syphilis. And so we should only concentrate on the ones that don't screen for syphilis at the moment. And so we're happy to do that. But when we did our baseline study, we found that only 7 out of the 51 facilities actually screen for syphilis for different reasons. And so in that case, actually, then introducing rapid syphilis tests into that region makes a lot of sense because of the high prevalence in particular. And so we're really happy that with this 7-country study that was funded by the Gates Foundation, that actually, because we engaged policymakers right from the beginning, and we did a lot of quality assurance, a lot of training, all 7 countries changed policy to adopt the rapid test for their screening programs before our research was even finished. Our research actually officially finished on December 31st this past year. Now, we always say we want to have point-of-care tests because that would be the simplest thing to increase access. So when I was tired of talking to donors and saying we need affordable, sensitive, specific tests, so I coined this acronym ASSURED to represent the kind of benchmark that we want to go for, something that's user-friendly, that gives an answer in maybe 30 minutes. It's very robust so that you could ship it at room temperature, and it has a long shelf life. And maybe it doesn't need to use equipment, or it uses a small piece of equipment that could be powered by solar power or battery. And most important of all, it's deliverable to those who need them. Now, when I talk about point-of-care tests, one time I was talking to Ray Waters, who's a vet, and he said, yeah, when we talk about a point-of-care test, this is a point-of-care test. So he's been told that they suspect that this elephant has TB. I don't actually quite know how you know that an elephant has TB. Do they cough? I don't know. And how do you get sputum from an elephant? I don't know that either. But anyway, so their point-of-care test is when an elephant is suspected of having TB, you bring your test to the elephant, right? But this takes 6 hours to set up. 4 people have to hold the elephant still to get a good image. And so I think when we talk about point-of-care tests for diagnostics to try and improve global health, we really need to think about what's the test that we need, who's it for, who's the patient, what setting, and what purpose. Sometimes you want a rapid test not to diagnose infection, but you want it for surveillance. You want to look at the effect of an intervention you just introduced. So, and also who will do the test, that's important. Now, in terms of a point-of-care test, we always think of a test like HIV, a test for syphilis. So we now, after a lot of years, we now have a lot of rapid tests for malaria. And so every country is really happy if they do have a lot of malaria to have these rapid tests. Because for those who have no access to a lab where microscopy is done, a rapid test really works well. But the fallout from introduction of rapid tests for malaria is that in a study that was done by Valérie Decremont from the Swiss Tropical Institute, now called the Swiss Institute for Public Health, they monitored in Dar es Salaam with the introduction of rapid malaria tests, what happens to prescriptions. Now, they're happy to see that before the introduction of the rapid test for malaria, there were a lot of antimalarials given to anybody who presented with fever, and there's a reduction to from 81% to 24%. But concomitant with that is a big increase in prescription for antibiotics, because the doctors say, here's a mom with a sick child with fever. What do I give her to give to her child? If I don't give her antimalarials, she'll just leave the clinic and go to the shop and get antimalarials. And those antimalarials may be fake ones or substandard ones. And so it's better if I give her antimalarials. And so this is my pitch for the fact that we should look at multiplexing. And the ability to multiplex is one of the things that very clever engineering students can do, hopefully here, right? And there are new technologies out there. Sam Sear, who spoke at this symposium last year, he's published a paper in Nature Medicine to describe his microfluidic device that could actually detect HIV and syphilis at the antibodies at the same time. And you could see that the device is very small, and we're asking him to actually make that into a device that can be used as diagnostics for prenatal care. For example, to incorporate anemia test for anemia in there. And so this can be read with a small reader, which then actually allows you to transmit the data to a central database. And we also want him not only to just do that, but actually link it to supply chain management software, so that with each test result that comes in, you know that a test has been used in that facility. And if you build a GPS into there, you know exactly where this result's coming from. So there's a lot of possibilities with these new devices, and I'm sure Luke has a lot of them as well. But now I want to talk about, in general, I know that Valerie talked about developing drugs and how long and how hard it is. And I want to take you through this bench to bedside diagram pathway for development of diagnostics. So in terms of the R&D, usually is about 2 years if you already have all the monoclonals and you are just adapting a test. But a new platform usually takes about 10 years. And it's a smaller investment than drugs, but still a sizable investment. And for the drug world, they have a large valley of death, where you start with a lot of promising leads, maybe 100,000 leads, and you end up with one drug going to market after 15 years. So we don't know what the valley of death is for diagnostics, but we hope it's not as deep and it's not as bad. But we do need to actually shorten the time for development. And then once you have a good prototype, you need to go through the trials. And the regulatory approval process at the moment for a lot of countries take between 2 to 5 years. And then in terms of policy and uptake, normally countries would like to see, with a new technology, they like to see a lot of publications, they like to see systematic reviews, so it takes between 5 to 7 years. So if you add this up, it's a lot of years. It's 20 years from beginning to end if you were going to start with a new device. And so, for example, for typhoid, we had a meeting that was sponsored by the Gates Foundation to look at a better diagnostic for typhoid, because not everybody can do culture. So for typhoid, if we want a new platform for typhoid diagnostics, we're at this point. And so I would hate to think that 20 years later, it would be useful in the developing world. So in terms of knowing what we need to do, we need to work at not only making the bench to bedside pathway shorter, but also less costly. Now, one of the areas where we find with all these new, really good technology that is evolving right now is that there's a lot of money that is spent on regulatory approval type trials. And so this is a small point-of-care device for CD4. And as you know, for HIV-infected patients, a CD4 test in the developing world is what makes you eligible. If you have a CD4 count of less than 350, that means that you're eligible to receive HIV drugs. And currently, because the normal sort of FACS cell count type CD4 assays are very, very costly and require sophisticated equipment, a lot of HIV patients don't have access to CD4 counts, even though they know they're HIV positive. I think the estimate is something like 11 million HIV-infected patients are waiting for CD4 counts. And so now a point-of-care device like this is very useful. But the company is having to do 27 trials or 29 trials just in Africa alone, and 42 all over the world. So the cost of that trial and will be added to the cost of the product, and also the length of time for this approval is actually delaying getting the product into countries. So that's something that we need in terms of harmonization. And there are a lot of new, very innovative products for CD4 counts that are coming up. And these are all small countries that may not have the capital to do all these trials and therefore may not be able to get to be sold in developing countries. Now, one of the biggest improvements in TB diagnosis is the arrival of the GeneXpert platform. And David Persing, the vice president of Cepheid, that actually the company that makes it is here. So you could ask him about the details of this. But I think it's the first of what we are trying to promote as plug-and-play devices. Literally, you could just put a sputum into this barcoded specimen cup, let it solubilize for a little while, and then insert it into any one of these slots. And an hour and 45 minutes later, you will have a TB result, and also whether the TB is rifampicin resistant. So that can be used at the point of care. And I hope that the company wouldn't have to do the 42 trials around the world, and that this could be used. And South Africa has already been funded to introduce these tests into South Africa. And they will have, the company has other platforms like chlamydia, gonorrhea, and HIV viral load coming using the same technology. So it's really good. And also, you could have random access. So you could run one TB and one chlamydia side by side on this. And that's the kind of platform that we're hoping for will be very useful in the developing world. But in the meantime, if we don't do something about getting these countries to stop having to demand regulatory trial in their own country over and over again, we will have to wait years and years for these products, even if they're available today, to be introduced into countries. And if we look at the WHO statistics, 1.8 million people die a year of TB. And so how many TB patients will die waiting for an affordable and effective diagnostic test? And you can do the math. So really, it's really urgent that we try to do something about shortening that pathway. So one of the things that we are trying to promote is the 3 R's of partnership, where if we share resources, if people who are doing discovery actually share their target databases, and when I was in WHO, we do have a TDR targets, which is actually a shared database that was subscribed to by Pfizer, Serono, et cetera. So companies are willing to share their target databases, and we're trying to do the same thing for diagnostic target discovery. There are shared risks in this valley of death, but in the end, maybe if we all collaborate, we'll share rewards. And so that's what we're trying to promote. Now, one of the new things that have happened in the last 2 years is that the Gates Foundation, together with Grand Challenges Canada, had invest quite a lot of money into point-of-care diagnostics. So the call for proposals for the Gates Foundation was launched in 2009, and they had over 700 LOIs, letters of intent, that were submitted, and 60 were asked to submit full proposals. And the Canadian Grand Challenge was on the similar kind of call, but they added a specific component for developing countries. And their call is only open to developing country scientists to try to motivate developing country scientists to go into diagnostic development. So together, between the two, there were over 900 letters of intent submitted, and many of them were really brilliant. And in the end, there were 84 proposals, full proposals that had to be judged. And it was really, really difficult. Many of them are so innovative. You know, I wish that all of them could be funded. But in the end, only 24 were funded. And actually, 2 of the grantees are here. Luke and Rebecca are both grantees. So they are absolutely the cream of the crop in terms of innovators. And so I think that we have a good chance at getting really good diagnostics to be ready in maybe about a 5-year time span. So the way the point-of-care diagnostic work is that in phase 1, which would last 3 years, each one of the grantees have been funded for one of these categories: sample collection and preparation, amplification, signal transduction, and enabling technologies like connectivity, et cetera. And then the Canadians funded the 5th one, which is the implementation research of how to get the point-of-care device into developing countries. And at the end of the 3 years, the best in class of each one of these categories will be asked to work together to come up with the device. And so it's anticipated that there'll be 1 or more platforms that would be available. And so in the end, what we want is to have something that is interoperable. And so the idea would be to have a base station which is open access. So any company can develop a test using those base stations. So the analogy, the simplest analogy is that you can buy a memory stick from any company and it will fit into any computer and work. And so that's the kind of interoperable conditions that we want to make it as flexible as possible, because if you have a child presenting with fever in Malawi, the causes of fever would be different than a child presenting with fever in Thailand. And so you need to have a base station that would allow you to put in those, the right kind of diagnostics. And we want to reduce the barriers to entry into global markets and eliminate the need for expensive instrument development. We want to have remote quality control of these instruments, et cetera. And we want to achieve a harmonized regulatory environment. And so parallel with that, when I was in WHO, we started an African network for drugs and diagnostic innovation. And with that, we also started one in Asia and one in America. And so the acronym for this network is ANDI for Africa, but it's also ANDI for Asia, also ANDI for America. So now we have 3 ANDIs. And they're all working to some extent. The idea of ANDI is also to try to have developing country scientists to work with others who are leaders in the field to develop technology for diseases that are important in their region. And one of the big things that we want to do is to have also technology transfer and local production. And I want these sites in Africa, in our Asian and American networks, to be sites where you could take your instrument and try it out in developing countries in terms of the heat, the dust, and humidity, to know that it would work in those conditions before you package and seal it all up, right? And so that's the kind of collaboration that we want. So the way forward, and this is my last slide, and is that now there are more funding, more players, and there are unprecedented opportunities to improve global health by the development and delivery of accessible, quality-assured diagnostics. And developing countries can play a really significant role. But one thing that is really important is we do need the technology. We need innovation in technology, but we also need innovation in delivery, because having the test, as we saw, just even with the rapid syphilis test, as simple as this, introducing in countries have been a major, major effort. And so we need to have innovation of delivery of our very ingenious devices. And that integration into vertical programs in countries is also very important. And so, thank you very much.
Thank you for excellent talk. Any questions?
Hi, thank you. I was wondering if you could comment on the relative value of investing in new platform technologies versus expanding the availability of tests for multiplexing on single platforms. For instance, if the Cepheid device is already being rolled out in places like South Africa, it seems like it would make more sense for South Africa to just build more add-ons to that platform rather than investing in new platforms. And could you talk at all about what's going on in terms of investment in platforms versus tests?
Yeah, as I said, in terms of the development time, a new platform, investing in a new platform, it's a long investment and a very, very expensive deal. I think that while we're waiting, and there will be people who have the money and who have the persistence to really go at this, and we do need new platforms. I mean, we need a tricorder. But in the meantime, we'd like to encourage people to use existing platforms and to expand them or adapt them. And, but I think that one of the things that we like the developing countries to be able to tell us is that, for example, when I was at WHO, for TB, WHO endorsed 4 new technologies. So one is, the first one is the midget, which shortens the time of culture from weeks to days. And then the line probe assay for drug susceptibility. And then the LED microscope to increase the sensitivity of microscopy. And then also the GeneXpert, right, the platform. Now, countries need to take all these new technologies and the WHO endorsements and say, okay, do we take all of these technologies? Do we take one? Do we take 2? And where do we deploy these technologies? Are there places where we can only do microscopy, therefore we invest in the LEDs, et cetera? Wendy Stevens in South Africa has got some funding to actually map out where the laboratory services are and where the TB cases are so that she knows where to put different ways. And I wish that kind of mapping, the technology assessment and the mapping of where services are needed and what technology goes with what level of the healthcare system, that's very important, and we don't have a lot of the data.
Any other questions? Yeah, over there.
You talked a little bit about distribution of various tests and the competitive environment that may differ in different countries for different types of tests. Yeah. But I'd like to hear a little bit more, based on your work at WHO, on how often are those decisions made at sort of the Ministry of Health level in a certain country versus at very local levels? Who's actually making the decisions to buy or use which tests?
Yeah, it varies from country to country. For big items, the diseases of mass destruction like TB, HIV, and malaria, quite often there are national programs that make those decisions. But for tropical diseases, for example, maybe, for example, for leishmaniasis, there are only parts of India which, where it's a problem. So those states will make their own decisions on what to buy. There isn't a federal or, national program that decides that. But quite often what happens is that the procurement decisions are made outside of health programs. So I've been approached in one country where we evaluated a lot of tests for leishmaniasis, and we found, what the best one was. And the Department of Health thought that, the country would agree to buy that because it's now in the WHO bulk procurement program, and they could buy it for a negotiated price. But it turned out that the procurement part of the country decided to do a tender, and they bought the cheapest test. And the Department of Health knew that the cheapest test is a fake test and has, like 0% sensitivity. But they couldn't, and they asked me to interfere, but I cannot overcome a procurement decision. And so those are the things that we need. If we need to create more capacity in developing countries to make those good decisions. And until that happens, we cannot get rid of all these bad tests that are, wasting a lot of very precious resources. And a lot of people pay out of pocket for these tests that are no good.
Any other questions? Oh, one more.
Excellent talk.
Thank you.
I would like to ask about the people who actually use this diagnostic point-of-care devices in the developing world. How do you select those people and how do you train them?
You mean in my project or in general, in introduction?
Say in general.
In terms of your country program, for example, let's take the syphilis example. When we go to a country, we ask them if they have a policy for screening pregnant women for syphilis. And if they do, what kind of test do they use? And they would say, oh, we use RPR or whatever, which is a laboratory-based test. So then we say, okay, here there are point-of-care tests that you could use, and you could actually use it down to the health post, the dispensary level. And it's up to the country to agree whether that could be done or not. Sometimes in some countries, there is a problem with tests can only be done by laboratory technicians. And also the treatment can only be given by doctors. So in a village where you don't have either a lab technician nor a doctor, but you have a frontline health worker, you may not be able to do the test nor give the drug, right? So it depends from country to country, but on the whole, different country programs have been very receptive. They see the benefit of increasing access to diagnostics as a way to improving the healthcare system and have better health outcomes for the country.
Maybe I'll ask you one short question before coffee break. What is the most difficult part for harmonization?
Look, you shouldn't ask this question. The problem with harmonization is that for regulatory approval, the primary mandate of regulatory authorities are twofold. One is safety. They need to know that the device you introduce would not kill anyone, right? And the other is effectiveness. And I would submit to you that a lot of the regulators do not have a really good sense of what is effective. And even for healthcare programs, what is effective is sometimes setting specific and indication specific. If I want to screen patients for a disease, the screening test should be very, very sensitive. And then you can confirm, you can improve the specificity by confirmation after you did your general screening. But if you want to use a test for surveillance, it has to be specific. Otherwise, you have a test for cholera that is not very specific. You would misidentify a lot of cases of watery diarrhea as cholera. So I think that is not the purview of the FDA. So I think that there has to be more collaboration between the FDA and the health departments to actually come together to make those decisions. But traditionally, they are separate in government, and that's the tough one.
Thank you very much for your excellent talk. Okay. Mm-hmm.